Copyright Stanford University, all rights reserved.
So, we often talk about the effects of myotonic dystrophy on the GI tract and on the heart and certainly on sleep, but to have people here who know those fields in more detail is going to be really helpful to all of us. So I look forward to learning along with you. So the first up is Dr. Linda Nguyen, who runs the Dysmotility, or the Motility, how do we call it? The Motility Center here at Stanford. And you need to be aware of the importance of having that here. Motility experts are unfortunately few and far between, with most gastroenterologists focusing on endoscopy and looking for structural changes rather than functional changes. So it's really with a great pleasure that Dr. Nguyen is here, and I look forward to what you have to say. So thanks a lot.
Well, thank you for inviting me. And what I'd like to go through is just in terms of the GI symptoms, and I'm sorry I missed the earlier presentation where everybody raised their hands in terms of who had GI symptoms. But when you, in the survey studies, it looked approximately a third of patients, and these were in the earlier studies, had GI symptoms. And it involves both the skeletal muscles, the myotonia, which involves the upper esophageal sphincter, and the anal sphincter, smooth muscle involvement, which is the rest of the GI tract in between. Interestingly, though, the GI symptoms may also precede the diagnosis of muscular dystrophy by several years, initially with symptoms of cramping, altered bowel function, where you may have been diagnosed with irritable bowel symptoms before having the muscle weakness. In several different studies, the GI symptoms, predominantly constipation, has been felt to be one of the most disabling symptoms among all the symptoms that plague this patient group. Muscular dystrophy can affect the entire GI tract with symptoms of difficulty swallowing or coughing, and that can involve the oropharyngeal dysphagia, so the swallowing mechanism. You can present with esophageal dysmotility, predominantly weak peristalsis and weak lower esophageal sphincter, giving rise to acid reflux, nausea and vomiting due to gastroparesis, abdominal pain, which can be due to a variety of different things, including the gastroparesis, but also pseudo-obstruction, gallstones, sphincter of Oddi dysfunction, constipation, irritable bowel. Constipation without abdominal pain can also occur. This can be slow transit constipation, spasming of the anal sphincter, or more seriously, megacolon. Early on in the studies, actually diarrhea was found to be a very common symptom. But the thought, as some of the data has evolved, is that this diarrhea may be more of an overflow diarrhea, because the transit is slow, that only the liquid stool can come around, and potentially due to bacterial overgrowth because of slow motility in the small bowel. And then there's fecal incontinence, which can be due to weakness of the anal sphincter, but also pelvic floor dysfunction and trapping of stool in the anal canal and the distal rectum. So what's the prevalence of GI symptoms? This is comparing the type 1 and type 2 myotonic dystrophy, and the top 3 symptoms are dysphagia, or difficulty swallowing, abdominal pain, and constipation. And because I can't, in 20 minutes, go through the entire GI tract, I thought for today's talk, I would focus on the lower gut with colon and some anorectal function, but looking at how bowel function impacts quality of life. For all of you know that myotonic dystrophy affects health-related quality of life. And there are several factors in multivariate analysis that has been associated with this decreased quality of life, but constipation here is one of them. So in multivariate analysis, constipation has come out to be a predictor of decreased quality of life. And there's actually something we can do about constipation. I mean, there are lots of therapies for constipation. But first, you have to define constipation. And it can be defined as straining, hard or lumpy stools, a sensation of incomplete evacuation, which a lot of us forget to ask about, a sensation of anal obstruction or blockage, feeling the urge to defecate but not being able to evacuate, needing to use manual maneuvers to facilitate defecation. Again, this is something as a patient that it may be embarrassing to volunteer, so as a clinician you need to ask. And looking at the frequency of bowel movements, which is having less than 3 bowel movements per week. This is a question that most people will ask, and most doctors will ask, but the rest of this we tend to forget. And I apologize for those of you who have just eaten, but this is actually a very important stool scale, and it's because we need to be all on the same page. Because when you tell me you're constipated, I may think this, but you may be telling me that this is what your stool looks like, but you're straining too hard, or a little bit of this type 7 stool comes out, but you still feel full and incomplete evacuation. So treatment really depends on what the stool consistency looks like, because that can change what medicines I use. Normal, what we're aiming for is this type 3 to 4 stool. There are cards you can buy. They have T-shirts, mugs with this stool scale on it, if you're all interested. But you can also just type in Bristol stool scale on the internet, and the picture will come up. So what's the difference between constipation and IBS? A lot of people use this interchangeably. The difference is that constipation can have bloating and those alterations in the stool consistency and bowel habits, but there's no abdominal pain. Presence of abdominal pain or discomfort is more consistent with IBS than constipation. And it doesn't. And again, patients may not complain of pain. They may say discomfort, a sensation of fullness. So you just have to clarify what each individual means. So what's the purpose of the colon? The colon's there to absorb water and electrolytes, and it does this very efficiently. So the longer the stool sits there, the drier the stool gets. Absorbs short-chain fatty acids. Salvages carbohydrates, so anything that your small bowel does not absorb, the colon will absorb. And then it moves the colonic content from the right colon down towards the rectum and sigmoid colon, and where it waits to be evacuated. And then there's the question of continence. There's a sigmoid break. So the sigmoid colon actually contracts kind of a to and fro manner to prevent stool from going into the rectum and leading to fecal incontinence. There's the compliance of the rectum, or the pliability of the rectum. So the rectum is supposed to be able to stretch and allow the stool to remain in the rectum without causing extreme urgency. People who've had radiation to the rectum can have decreased compliance or any type of surgery in that area. Rectal sensation, so if you have rectal hyposensitivity, so you're not feeling the stool when it's there, then the stool will overcome the pressure of the anal sphincter and lead to incontinence. And then the muscles down in the pelvic floor, you have the puborectalis, which is here, which is a striated muscle. The internal sphincter, which sits up here, that's smooth muscle, and then the external sphincter, which is striated muscle. So during rest, when you're not having a bowel movement or you're not squeezing the sphincter, 80% of the sphincter tone is made up by the internal sphincter. And so you can actually measure rectal function, and we do this here in our lab using anorectal manometry, and it's a little catheter that you put into the rectum and anal canal, and you can measure pressures. And so this is a resting pressure here, and you ask the individual to squeeze, and you see an increase in the pressure that's maintained. So if someone has fecal incontinence, you may see a weakness in the squeeze pressure, or you may see a normal squeeze pressure but early fatigue. So you can kind of squeeze, the individual can squeeze but then get tired out easily. And then these are some reflexes that you see. So when you blow up a party balloon or cough, there's actually a reflex increase in the anal sphincter pressure, so that when you cough, there's no incontinence. And then when one bears down, you see an increase in the intrarectal pressure and relaxation of the sphincter pressure. So these are all normal anorectal function. And I'll show you this data later, that in the setting of muscular dystrophy and a lot of other conditions, there can be abnormalities in the anorectal function. So when you think of constipation, you have to think of the colon as well as the anal sphincter. So if there's delayed colonic transit, you can see altered smooth muscle activity, so more of a myopathy, or you can see a neuropathy where you can see any abnormalities in the enteric nervous system. Autonomic dysfunction, so if you have decreased parasympathetic function, then you can lead to slow colonic transit. And then decreased mobility, so not exercising, not being able to walk around because decreased transit. And then anal sphincter dysfunction in myotonic dystrophy has been reported anywhere between 50 and 90% when studied. So this study here was actually done looking at combined esophageal and anorectal manometry in patients with myotonic dystrophy. I believe there were 18 patients involving 3 families. But essentially what they found was that the resting sphincter pressure was actually normal or low normal. So it wasn't that there was extreme weakness in the resting sphincter pressure. The squeeze pressure was weaker. And then you can see because of the striated muscle in the puborectalis and the external sphincter, there is something called the rectal anal inhibitory reflex, that when you blow up a balloon in the rectum, there is a reflex relaxation of the anal sphincter. So this reflex is intact, so the sphincter relaxes, but then in the recovery phase, in the myotonic dystrophy group, there was a spasm. So there was a prolonged increase in the contractions in the recovery phase. And then pelvic dyssynergia, which is what you see here, I'll show you again. During bearing down, you see an increase in the intrarectal pressure and a decrease in the anal sphincter pressure. Pelvic dyssynergia is when you do the opposite. So here is an increase in the intrarectal pressure, so someone's bearing down, but the anal pressure is also increasing. So you imagine that you're pushing down against a closed door. And the harder you strain, actually what you're doing is you're recruiting the gluteal muscle, so you're increasing the pelvic floor muscles, the pressure even further, making it harder to defecate. And in myotonic dystrophy, oops, my numbers didn't show up, but the percentage of pelvic dyssynergia was over 50%. Interestingly, in the sort of general population, when you look at patients who come in with constipation that's refractory to the usual therapy, we can see pelvic dyssynergia in about 60%. So it's very common. So then treating constipation, you have non-pharmacologic, pharmacologic therapy and surgery for absolutely severe patients. In the non-pharmacologic therapy, there's exercising, so if you're able to increase activity, diet, and then pharmacologic therapy, I'll go into a little bit more detail. With the diet, you have soluble and insoluble fiber, and there's definitely a difference. So the goal is to get about 20 to 30 grams of fiber per day. Don't overdo it, because more than 30 grams does not increase the rate of bowel movements, but increases bloating, gas, and any discomfort that can occur from this excessive bloating. So soluble fiber, think of it as glue. It attracts water and forms a gel, so it can slow gastric emptying. But also, if someone has the type 6 or 7 stools, the more loose stools, you want to use soluble fiber to help kind of bulk the stools and keep the liquid together. So some of the foods you can see are dried beans, oat bran, rice bran, apple, strawberry. So these are natural soluble fibers. Then you have the insoluble fiber, which adds bulk to stool, increasing the colonic transit. So you can see that with wheat bran, whole grain cereal. The fiber supplements that are out there are soluble fibers. So Metamucil, Fibercon, Benefiber, those are all soluble fibers. So then the other diet, there's FODMAPs. And what are FODMAPs? Are these fermentable foods. They're oligodimonosaccharides, so they're sugars that are highly fermentable, and they're all based out of fructose. So fructans are polymers of fructose, and sorbitol it's just an artificial sweetener. But all these foods are highly fermentable. It doesn't improve bowel movements by eating a low FODMAP diet, but it minimizes the bloating and excessive gas that one gets when you're constipated. So this was a study done looking at gas production. And so they had healthy individuals and patients with IBS consume a high FODMAP diet versus this low fermentable diet and measured gas production. And in both the IBS patients and the healthy controls, that when you consumed a high FODMAP diet, there was more gas production. The difference was that the IBS patients had symptoms based on this gas production. So again, the FODMAP diet can be restrictive, but if someone's complaining of excessive bloating, gas, this is a diet to help with that. So pharmacologic therapies, fiber, if the dietary fiber is insufficient, you just, like I said, be careful with overutilization of fiber because it can lead to excessive bloating and discomfort. You have the osmotic laxatives like lactulose, magnesium, Miralax, the stimulant laxatives, which we're all familiar with. But what I want to talk about is the prosecretory agents, which as gastroenterologists we use a lot, but I find that people in primary care or other groups outside of GI are not comfortable using, but they're actually good medications. They're Lubiprostone was the first one that came out. The trade name is Amitiza. It's FDA approved for both IBS constipation and chronic constipation. It activates luminal chloride channels, so it increases secretions in the small bowel and increases motility. And you can see here that while they're on the Lubiprostone, the percentage of patients over here versus placebo feeling a response or improvement is higher. The other one, which came out about a year ago, is Linaclotide or Linzess, which is FDA approved, again, also for IBS-C and chronic constipation. It activates guanylate cyclase receptors and, again, increases luminal secretions and colonic transit, but this is using the CFTR chloride channel instead of the CLC2 ones. And again, you see here, this one is looking at the complete spontaneous bowel movement. So patients feel like they've had a good bowel movement and not just, an inadequate bowel movement. And you see that while on therapy, that there is an increase, there's an improvement in symptoms. And then colonic inertia sort of differentiate from slow transit constipation, those that are refractory to everything, where there's really an absence of either contractions either stimulated by a meal or with medications. You can try something like neostigmine or pyridostigmine, which is an acetylcholinesterase inhibitor, and that can increase colonic contractions. Bethanechol, which is an acetylcholine agonist, again trying to increase colonic contractions. And then for the very refractory patients, you can do a subtotal colectomy, either with an rectal anastomosis if there's normal pelvic floor function, or do a total colectomy with ileostomy if the pelvic floor is not functioning well. And then I'm going to run over just a little bit, but I wanted to spend some time and talk about defecatory disorders and how to treat that because it is so common. The dysenergic defecation you treat with biofeedback therapy. So there have been studies using, antispasmodics, looking at Valium, to see if just relaxing the body in general will help with pelvic dyssynergia, and it's really not effective. Biofeedback consistently has been found to be effective in treating dysenergic defecation, and what you're doing is you're teaching the individual to relax the pelvic floor, specifically the puborectalis and the external anal sphincter, and then coordinating with the increasing abdominal pressure without increasing the gluteal muscles. And then if that doesn't fail, unfortunately, because the medications don't work, then you may need to talk about doing a colostomy for very severe cases. And then look for things like rectoceles or rectal prolapses, which are essentially weaknesses in the rectal wall where you can get stool trapping in there. But more commonly, we're dealing with the dysenergic defecation. And generally, what I tell patients to do in the office before I send them out for biofeedback therapy is to say, when you're straining, just push with 50% or less of your maximal force. And if you're still having problems, actually, put your hand on your your gluteal muscle and make sure that's not contracting. So you want to contract your abdominal muscles, but not contract your gluteal muscles at the same time. Doing abdominal exercises like sit-ups to increase the strength of the abdominal muscles does help. Doing Kegel exercises doesn't help with the relaxation, but it helps develop awareness of the pelvic floor muscles, because oftentimes, you know, the muscles are there and they do or they don't do what they're supposed to do, but we're not sure what they're really doing at the time. Timing of bowel movements after meals. So there's something called the gastrocolic reflex. So when you eat, that increases contractions of your colon. So there are some people who have a very strong gastrocolic reflex, so at the end of dinner, they're running off to the bathroom. What you want to do, though, is if you feel that urge, don't defer that urge to defecate. You know, try to go to the bathroom as soon as you can, and go when you have the urge. When you sit on the toilet, minimally try to have your thigh parallel with the floor, and leaning forward a little bit can help relax the pelvic floor muscles. You can also get something called a squatty potty, or you can make something that looks like a squatty potty, which is, it looks like a step stool, but it wraps around the toilet. It allows you to bring your knees up into a squatting position. So again, that helps to relax the pelvic floor, and it also helps relax the whole body. And then after about 10 to 15 minutes, if it's not working, get up. Don't sit there. Don't strain excessively, and leave your iPads, iPhones, whatever, outside the toilet. So some of the pitfalls of medical therapy for constipation is making the stools too loose. So what you want to do is try to aim for Bristol type 3 or 4 stools. And what I tell my patients is that if you make it too loose, it's like you're making your rectum work too hard, because the rectum is trying to push against the stool, and if it's loose, all the stool is doing is just kind of sloshing around in the rectum. So it's a visual that helps patients to minimize overutilization of the laxatives. And then waiting too long to use rescue therapy. So there's this myth that if you use laxatives, you'll become dependent on it, it'll never work again, and so you should use it as little as possible. And then people wait a week before they haven't gone to the bathroom for a week, and then start using laxatives, and they don't work as well at that point. And then you start using more and more, and then you start getting cramping, diarrhea, and miserable. And so what you want to aim for is having a bowel movement at least 3 times a week. So if after 2 days nothing's happened, start taking the rescue therapy, and so that you're not going more than 3 days without a bowel movement. So just to finish up, the abdominal pain and constipation are common among patients with myotonic dystrophy. Constipation is one of the most disabling symptoms affecting patients. It leads to decreased quality of life. The early studies reporting the higher prevalence of diarrhea may be due to overflow diarrhea. So if you have someone who's complaining of diarrhea, then look for overflow. And the easiest way to do that is actually do a KUB, or an abdominal x-ray. If someone's having diarrhea, you should not see a large fecal load in the x-ray. So if someone's complaining of diarrhea, you do an x-ray and you see tons of stool throughout the colon, that's overflow diarrhea. And again, when you get an x-ray, the radiologists may not always comment on that, so I always look at the images myself. Treatment is aimed at increasing colonic transit through medications or diet, improving the stool consistency, so aiming for that Bristol type 3 to 4 stools, retraining the sphincter function. And, you know, as I treat a lot of patients with various GI dysmotilities, but with Dr. Day here, I'm learning more and more about the myotonic dystrophy. And what I found very disappointing was that there was very few studies that looked at these treatments specifically in patients with myotonic dystrophy. So all these recommendations that I've given to you today are based on just general treatment of constipation. Nothing specific to this patient population, and that's because there is zero data out there. Maybe some case reports here and there, but in terms of real scientific data, I spent weeks and weeks and weeks searching, and there is zero. So that,
great.
I'll leave you with that.
That was great. Great. So thank you very much, Linda. And I think that what we're going to do is we're going to hold questions until we all come up at the end. But I do encourage you, if that jogged any thoughts or questions, to write them down and wave them in the air, and somebody will come and get them or pass them to the side, and someone will pick them up so that we can address that. Now I need to get you back on, and you know how to do that. So next we're going to hear from Dr. Marco Perez, who's part of the Stanford Inherited Cardiovascular Group and specializes in some of the electrical disorders that can be common in myotonic dystrophy. So myotonic dystrophy can affect the heart in multiple ways. So Dr. Wheeler, I see sitting back there as well, and he's also in the same group, and so we have a multifaceted group in the cardiology department here who can help address different aspects of myotonic dystrophy. But today we decided to focus on the electrical or arrhythmia issues. And earlier, many people said that they had an abnormal EKG or ECG. So we'll be interested to hear from Dr. Perez about what to do about it. So thank you very much.
Well, it's a pleasure to be here, and I just want to say it's been a real pleasure to work with Dr. Day. We've shared many patients now over the last few years, and we're learning a lot about how to manage folks with myotonic dystrophy and a lot of the cardiac problems that they develop. So this is just a very, very brief overview of the heart problems that patients with myotonic dystrophy get. About a quarter of patients with DM do have a slow electrical system, and I'll go a little bit more into detail what that means. About 5% of patients with DM develop rapid heartbeats or arrhythmias, as we also call them. And it turns out that about 7% of patients develop weakening in the muscle itself, the heart muscle itself. Now, I'm an electrophysiologist, which means I'm sort of the electrician of the heart. Dr. Wheeler is more of the heart muscle specialist. And so I'm going to be talking a lot more about the electrical problems that can happen inside the heart. So the way I like to think about the heart is, the heart really is a pump. We know that the blood goes into the pump, and the pump then pumps the blood back out to the rest of the body. But like all pumps, the heart itself has electricity flowing through it. And you can see here from the picture, it's quite a complex electrical system. There are several branches or wires to the electrical system. And a lot can happen. A lot can go wrong with the electrical system. So what we find is that folks with myotonic dystrophy, and I mentioned before about a quarter, end up developing a problem somewhere along the electrical system. And the problems that you can see can happen anywhere along the electrical system. Sometimes the problems are very high up in the heart. Sometimes they're very down towards the bottom of the heart. And how severe the problem is really depends on where that electrical problem happens. What we'll often find, however, is that usually they're very early subtle signs that we can see very early on in the electrocardiogram. And often those subtle signs then progress, get more severe, and eventually what can happen is if you have a complete block in the electrical system of the heart, then the heart functionally will either stop beating or start beating very, very slow, dangerously slow. Now, why do folks with myotonic dystrophy develop problems with the electrical system? And this is I think this is one of the themes in the conference. We don't know. There's still a lot that we're learning about myotonic dystrophy and the effects on all of the organ systems, including the heart and particularly the electrical system. There are theories that there's some form of fibrosis or scarring. Perhaps there's a problem with the connections between the cells in the conduction system. And as we've heard about this morning, there are a lot of things that are happening inside the cell at the molecular level that we're still learning about. And we know that these clumps of mRNA do interfere with other parts of the cell that can then, such as the calcium handling machinery, that can then interrupt the conduction system. So again, we're still learning a lot, and as we go, I think we'll learn more and more, and we'll learn how to better handle a lot of these problems. Now, I mentioned that, that the problems that we can see, the electrical problems that we can see in the heart, we can start seeing them way before you have any symptoms. So very, very early on, what we can find are different types, different severities of problems on the electrocardiogram. So I was here earlier when folks raised their hand, and I was very happy to see that almost everybody here raised their hand when the question was asked, are you getting your EKG done every year? So that's very, very important because this is a progressive condition. It's very important to catch it early on. So many of you have had this electrocardiogram done before, and this is just an example of the types of abnormalities that we can see when we do the electrocardiogram. So here, for example, is a normal electrocardiogram. You see this small bump here just reflects the way that the top of the heart starts beating electrically, and then the larger spike that comes after that reflects the electrical system as it goes through the bottom of the heart. Now, in some folks with myotonic dystrophy, especially the more advanced electrical problems, you can see quite a significant widening of the electrical system going through the bottom of the heart. But this is something that sort of can jump out at you, and when we see this, we know that there's something abnormal and is likely to progress kind of quickly. But a lot of the findings that we're looking for are more subtle. So very, very subtle changes, such as an increased distance between the time that the top of the heart beats and the time that the bottom of the heart beats. So things like that are the other things that we look for. And when we see this in normal folks, folks without myotonic dystrophy, we might not make a big deal out of them. We might think, well, this is subtle electrical abnormality. It's not a big deal. It's probably not going to be a problem. But what we do know is that folks with myotonic dystrophy do progress a lot faster than other folks. And so when we see these abnormalities in DM, it does cause more concern. So as the electrical problems do progress, if they went untreated, you can start developing certain signs and symptoms. One of the more concerning ones is passing out. So if you ever do pass out, that's a big red flag. Let us know right away. But you can also develop other things, especially as your heart starts to slow down quite a bit. You can get some chest pain, shortness of breath. You can become dizzy. These slowing of the heartbeats can come in waves or just in transient episodes. Some folks report feeling like their heart is skipping. And ultimately what will happen is that the heart slows down so much that it stops beating. And that's exactly what we're trying to avoid. So the treatment in those who do develop problems with the electrical system is really a pacemaker. We don't have any medications or any other types of therapies yet for this kind of problem. But so really what folks with the electrical problems need are pacemakers. So right now we place pacemakers in those patients with DM who have any signs of electrical slowing on the electrocardiogram. This can be either on the EKG, or if you wore a monitor and we saw that, then we would recommend a pacemaker. And again, as I mentioned before, this is why it's very important for you to have your yearly electrocardiogram, because as soon as we find these electrical abnormalities, that's the point where we recommend the pacemaker to prevent the heart from slowing down too much. So what does a pacemaker do? And I did see that a few people in the audience do have pacemakers and/or defibrillators. So the pacemaker is really designed when your heart slows down too much to give you a small electrical pulse. So it'll give you a small electrical impulse inside your heart to help your heart start beating again. So for most people, the pacemaker there just sits there, and it's always looking to see if your heart slows down too much. So you may only have very subtle abnormalities in your electrocardiogram. We may place a pacemaker, and it may just sit there as a backup for years. But eventually, when it looks and it doesn't find that you're having your own heartbeat, it will start delivering these small electrical impulses to help your heart start beating again. So this is how we place it. So we have a specialized operating room. This is the operating room here at Stanford that we use. And what we do is we make a very small cut and right under the left shoulder. We find the veins that then we place wires in through, and then we connect those wires to the heart muscle itself, and then we connect those wires to the pacemaker, and the pacemaker goes right under the skin over the muscle. So usually the procedure itself takes about an hour or two. We do know that patients with DM do have special operating needs. And one of the most important aspects is really anesthesia care. So fortunately here, because we do see more patients with DM, we have anesthesiologists who are very comfortable managing folks with DM. And you can have this done under conscious sedation, which means that you're very sleepy, but not quite put fully to sleep. And other times, other folks are placed completely to sleep. Again, with special needs, we avoid things like paralytic agents. So the recovery is usually, we keep you overnight in the hospital. If everything looks good, then you go home the next day. You're sore for about a week. You have a few limitations in your movement for about 4 weeks. But after that, most folks just go back to their normal activities. Then we do check the device every 3 to 6 months, just to check the battery and so forth. And it's a procedure that we do very, very frequently here. We do hundreds of pacemakers here at Stanford every year, and the complication rates are quite low, less than 1% for a major complication. So those are the slow heartbeats. But what can happen with patients with myotonic dystrophy, and again, about 5% of patients that develop this, is that the electrical system it's almost the opposite effect. You can have very rapid heartbeats. And there's one condition in particular called atrial fibrillation that we see with greater frequency in patients with DM, about 5% of these patients. So what happens here is that the problem here lies more on the chambers on the top of the heart. So the muscle that sits at the top of the heart stops being able to conduct electricity efficiently. So normally electricity just flows very smoothly down from the top to the bottom. But here the problem is that the muscle itself that's trying to move that electricity forward isn't able to. And the electrical activity at the top of the heart becomes very chaotic and very rapid. And so that really drives the bottom of the heart to beat very, very quickly. So what somebody can feel if they go into this arrhythmia, this atrial fibrillation, is really one of the most common things that folks complain of is palpitations. They just feel like the heart is pounding or the heart is racing, and then often folks will feel fatigue, just start feeling very tired or short of breath. That's on one end of the spectrum. On the other end of the spectrum, there are folks who go into this very rapid heartbeat but don't really notice it, don't really feel it. So it varies quite a bit. Really, the way to make the diagnosis goes back to electrocardiogram. So on the electrocardiogram, we can see this irregular heart beating. So there are several ways to handle these very fast heartbeats. If you fall into the camp where you don't really feel the extra heartbeats or the irregular heartbeats, we may just make sure that your heart doesn't race too fast. We might give you some medications to slow down your heart a little bit, and then leave it at that. But if you are bothered by palpitations or you get fatigued or short of breath, then we have a lot of options. We have several specialized medications to help keep your heart beating normally. And these are called antiarrhythmic medications. There's a whole list that we have to choose from. And if you don't respond to these kinds of medications, then there are other options, more invasive options, such as an ablation. So an ablation is a procedure where we place a catheter, which is a very skinny, long plastic tube. We place it in through the veins down by the legs. We place these catheters inside the heart. We cross the wall that separates the right side from the left side. And then we place up several burns inside the heart, and we try to eliminate the areas that are triggering these very rapid heartbeats. Now, this is quite a complex procedure. This is not something that we jump to right away. We usually try medications first, and really only recommend this type of procedure if you're not responding to medications and you are still having symptoms. There's a lot of a lot of technology that goes behind this kind of procedure. We can do a special imaging study of your heart and create a three-dimensional model of it. We can bring that into the operating room. We can place catheters inside the heart, and we can see how the catheters move inside your own 3D model of your own heart and place several burns inside the heart to help eliminate these triggers of these fast heartbeats. Now, we have a lot of information about the medications and these ablation therapies in the general population, but again, because there just aren't as many DM patients out there, we don't have much data on how effective this is in the DM population. But in the general population, the success rates are about 60 to 80%, and some people need more than one procedure. But the risks of a major complication are not negligible. So the risks of a major complication are on the order of about 2 to 4%. So this isn't a decision we take very lightly, and we usually do try several medications before we have to get this far. The other aspect that is very important is in managing somebody with these irregular fast heartbeats, this atrial fibrillation, is prevention of stroke, and that's really one of the main complications that can happen from a condition like atrial fibrillation. Depending on some of the other factors that we might see, depending on whether or not you have any muscle problems in your heart, we might recommend aspirin, or we might recommend something stronger such as Coumadin, or one of the newer blood thinning medications. So atrial fibrillation is the most common sustained arrhythmia that a lot of folks with DM have. Now, there are even more folks, however, who have just single extra heartbeats. The rates of what we call ventricular premature beats, or PVCs, is as high as about 14% in patients with DM. Now, I would say the vast majority of patients, or the vast majority of people, will have a few extra heartbeats, these PVCs. And these PVCs are just electrical impulses that come from somewhere in the bottom of the heart. Now, normally, the impulse starts at the very top of the heart and goes smoothly all the way down to the bottom. But here, there can be some irritation or something else happening in the bottom of the heart that causes these extra impulses. And the vast majority of people in general will have a few of these. But there are a handful, and especially in DM, we see that a large number of patients with DM, about 14%, have more than just a few PVCs. Now, many folks just don't feel these, but there are a few who feel them very frequently, feel them as extra heartbeats or pounding heartbeats. So they can become symptomatic, especially as they get more and more frequent. Usually we just keep an eye on them, but if they get to be very frequent, on the order of about 20%, or if they're starting to bother you, then again, we have the options of either medications or even ablation, where we can try to burn the areas that are causing these extra heartbeats. Now, this is one of the electrical conditions that worries a lot of us. So, what we do know is that about 1 in every 200 patients with DM die suddenly every year, and this is one of the most difficult aspects, really, to manage in folks with DM. Now, we don't know exactly why these sudden deaths happen. We do suspect, because of all the electrical abnormalities, that many folks with DM do have very, very slow heartbeats, and they can die from those very, very slow heartbeats. But we also know that many folks with DM have a dangerous fast heartbeats. So there's a type of fast heartbeat called ventricular tachycardia and ventricular fibrillation that can happen. And so if this happens, you might feel that your heart is racing very fast. If it's fast enough, you might pass out, you might collapse from this. And if it goes on for too long, it can be fatal. So the frequency of this is not really well studied, but we have seen several case reports of folks with DM. And in fact, there are folks who get pacemakers, folks with DM who start to have these electrical abnormalities. They get the pacemakers, so that records everything. And then they have these dangerous fast heartbeats. And the pacemakers really are not designed to treat the dangerous fast heartbeats. They're only designed to treat very slow heartbeats. And the treatment that you need if you were to develop this very rapid, dangerous heartbeat is an electric shock, just like you see in the movies, a shock that goes to the chest. Well, there are devices now that can deliver these electric shocks. So they're very similar to a pacemaker, but they're bigger, and they're meant to detect the fast heartbeats in the heart. And if you ever were to have one of these dangerous fast heartbeats, then you would get an electric shock that would get you back into the normal heartbeat. The nice thing is that the defibrillator does everything that the pacemaker can do, but it also has this other safety mechanism. The way that we place it is very similar, actually, to the way that we place a pacemaker. The risks are very slightly higher, but not significantly so. So the question, and this is one of the biggest challenges from our perspective, from the perspective of the electrical system, is who should get a defibrillator. And this is one of the most controversial areas in DM. In part, it's controversial and difficult to answer because, again, we go back to this a lot. We just don't have enough data, enough information. But what we do know is there are folks, as I mentioned before, that have these abnormalities, and sudden death is a concern. So what we've started to do, and what other centers are also doing, is that whenever we start to see these electrical abnormalities, the slowing of the heartbeats, the abnormal shapes of the electrocardiogram, we recommend not only the pacemaker, but at this point, we are also recommending a defibrillator. So that is something that again, is very, very early on in terms of the research, but it is something that we're doing, and we're going to learn a lot more about this as many more folks do get these devices, and we have more and more data. So I will mention this. So at Stanford, on the cardiac side, we do have now an inherited cardiovascular disease clinic. In fact, this is made up of several physicians. I specialize in the inherited arrhythmias. Dr. Wheeler, who's in the back, specializes in the cardiomyopathies, which means the weakening of the muscle of the heart, and these are all genetic disorders that we see. The myotonic dystrophy patients really fall into these two categories. So you folks develop not only the electrical problems, but also the muscle problems, and so we will have many of you see both of us because we'll specialize more on the electrical problems, and Dr. Wheeler will specialize more on the heart pump, the muscle problems themselves. And then the other aspect that I'd like to mention is that we really do have a team. There aren't many DM patients. We as a community are still learning how to best treat folks with DM, and I really do believe in the team approach. And so we discuss complicated cases. We discuss cases that we hadn't seen before, and we discuss this with a broad variety of specialists. We have adult and pediatric cardiologists, electrophysiologists, myopathy experts. We have geneticists, and we have a nursing staff that's very, very used to seeing folks with DM and folks with other genetic conditions. And Allison Smith, who's in the back, is the nurse that works a lot with us on the electrical side. She has many years of experience with pacemakers and defibrillators, and as we are, we're all getting more and more comfortable, or at least learning a lot more about these problems in patients with DM. All right, thank you very much.
Great, thanks a lot, Marco. That was wonderful. And again, we'll hold questions to the end, so that I do encourage you to, as you're thinking these things up, write them down and pass them forward so we can discuss this all. I think Marco again made the point of the importance of going to centers that are going to be able to take care of all the complex issues that come up in myotonic dystrophy. Does this connect? Okay. So last today, and we just kind of chose these things. So I encourage you, after the break, there are a number of things you can sign up on including there's a questionnaire about how this overall meeting worked, or maybe we'll have you do that towards the end of the day. But I would really love any feedback you have in terms of things that you think that we should cover in upcoming years so that we can really meet the needs of the community. Last, I wanted to emphasize another specialty of Stanford, which is the sleep center. So Stanford had arguably the first sleep center and has continued to emphasize the importance of studying and understanding and treating sleep disorders, which obviously is very, very complex in myotonic dystrophy. So not only is it prevalent, as was shown earlier by the raising of hands, where a large percentage of people here with myotonic dystrophy did note that they had increased sleepiness, but there's interesting biology behind that, and the more that we can understand the biology, we're really quite confident will help us to treat it better. So it's a multifaceted problem, as Dr. Ruoff will be able to share with us.
Hopefully.
It looks good.
It
Right. Looks like it's there.
Yeah.
Okay, so I'd like to thank Dr. Ruoff from the Sleep Center for joining us for discussion of sleepiness in myotonic dystrophy. Thanks.
Thank you for having me. So let's get started. The role of a sleep specialist in myotonic dystrophy. Probably many of you didn't even know before today or before you got the flyer that a sleep specialist is actually a specialist, or it even exists. But so let's get started. Maybe. Yes. So actually, when I started preparing for this talk, I thought I'd go to just a literature search and see how many articles are actually published on both myotonic dystrophy, and then compare that to how many articles are published on myotonic dystrophy and sleep. And just listening to the talks thus far today, sleep might be winning.
Yeah, I think so.
And that's not my message. That was not my intent of this slide. But let's go through. So articles on myotonic dystrophy as of last night. 2 days ago it was 5526, and then it went up to 5527 as of yesterday. Compared to sleep, myotonic dystrophy and sleep, 130 articles. I'm shocked that is paving the way in comparison to cardiology and GI, specifically looking at myotonic dystrophy and those specialties. Perhaps. I didn't do a search on GI, admittedly, or cardiology. But so what does this mean? It means we have a lot to learn. So, but let's just go through, and first I just want to teach you what a sleep specialist actually is looking for and seeing on a day-to-day basis. It's a fascinating field. So obviously the first and foremost thing that we're looking for, or not looking for depending upon your character and what kind of clinician you are, insomnia. So some of the various, this is just generalizations of how we approach insomnia, is pretty much threefold. One is just to teach about basic sleep hygiene. The other is medications, Ambien, Lunesta, Sonata, all these hypnotics. And then also here at Stanford, we actually have a fabulous behavioral sleep medicine program, cognitive behavior therapy for insomnia, which is great. And actually, when you do a head-to-head comparison between CBTI and medications, it actually comparable, if not better, than medications. So sleep-related breathing disorders. So of course, this is kind of what started sleep medicine back in the late 70s or so. Some of the initial descriptions were here, and some of the first treatment, actually, treatments were offered here back in the 70s, starting with tracheostomy. But we've made some advances, and we no longer actually, to treat a lot of these sleep-related breathing disorders, we no longer have to put holes in people's necks. So that's good, right? So that's sleep-related breathing disorders. So that makes up a lot of what a sleep specialist sees on a day-to-day basis. Lastly, this is an area that I'm definitely interested in. Hypersomnias of central origin, right? So sleep disorder breathing, the airway actually collapsing while you're sleeping can wake your brain up, and then you wake up and you're sleepy. But hypersomnia's central origin is that you've ruled out sleep apnea, or maybe you've adequately treated the sleep disorder breathing, and the patient still is persistently sleepy. And so some of the more interesting symptoms that can be reported by patients with these kind of conditions are sleep paralysis. As you fall asleep, wake up, you're paralyzed, you literally can't move. Or as you fall asleep, wake up, you're in this transition between complete wakefulness and sleep, and you're actually hallucinating. And it can be auditory, it can be visual. And then there's one other that's almost pathognomonic for narcolepsy, is cataplexy. So as you're telling a joke, coming up with something funny to say to someone, you actually have this involuntary loss of muscle tone, oftentimes triggered by positive emotion, but can also be anger and things like that. So that's hypersomnia as a central origin. Fascinating field. We've made a lot of advances in this field in narcolepsy in the last 10 or so years. Circadian rhythm disorders, very, very common in children with delayed sleep phase. You know, getting into high school, children often find that they have a lot of autonomy in their bedrooms late at night. It's the only time when the parents are away. So it's a question of whether it's just a reward mechanism or whether we're actually built, or whether it's biologic in that as we get in these teenage years, we get more and more delayed sleep phase where we're going to bed at 2 and 3 a.m. and then you're forced to wake up at 7 a.m. and the children are sleepy at school and everything like that. But and then on the opposite end of the spectrum, it's reported that as we age, we all know, advanced sleep phase disorder. Grandpa, he used to always go to bed at 6 p.m. and wake up at 3 a.m. and wake me up or something like that, right? So there's other kind of circadian rhythm disorders like advanced sleep phase disorder that we deal with. And then parasomnia is another fascinating field of study, just some kind of a movement or abnormality occurring out of sleep. And maybe you have no recollection for it in the morning. Sleepwalking, REM behavior disorder, acting out your dreams. There's actually been medical legal cases of where a spouse or something or bed partner has actually struck their bed partner, and they claim they've had a parasomnia or REM behavior disorder. So it's another fascinating field. And then movement disorders. So what makes up this category is primarily restless legs, and we'll talk a little bit about that in a second. So let's cover in those 130 articles that I showed you that are published in Sleep and Myotonic Dystrophy, what have they reported? So first and foremost, the literature is replete with this common message that myotonic dystrophy patients are sleepy. Independent of sleep disorder breathing, independent of everything, it seems like there's some CNS abnormality there where they're just sleepy. It's difficult as a clinician to tease apart fatigue and sleepiness. And so DM patients that there's both. And they both can definitely, unequivocally, it seems, affect quality of life. So hypersomnia. And then, of course, sleep disorder breathing. Restless leg, this is not as reported as much, but I stumbled across an article or two that was talking about it, so I just wanted to highlight that. And then a common mistake, actually, I encourage you to go home and if you're seeing your primary care doc or whatnot, and this somehow comes up, restless legs, PLMs, clinicians, doctors across the country and patients get these two mixed up. Restless legs is a sensation that you get as you're falling asleep while you're in bed at night. PLMs is kicking while you're sleeping at night. It is interesting that myotonic dystrophy patients actually have more PLMs than controls. There's literature suggesting that PLMs can actually increase your cardiovascular risk. This is very early on in PLMs, and PLMs in and of themselves are a little bit controversial, but there is some data showing that when you kick when you're asleep, you have a spike in your heart rate, a spike in your blood pressure. So teasing that out in the years to come will be interesting. And then I think I prefaced everything with saying this is the most fascinating thing, but another fascinating part of sleep in myotonic dystrophy is dream sleep dysregulation. REM, when you see the word REM here, it stands for rapid eye movements. When we dream, we have rapid eye movements. I encourage you to look at your bed partner tonight, if you've been afforded one, and watch them while they're sleeping and see if they have rapid eye movements. Then you'll know they're dreaming, and then you can wake them up and say, what were you dreaming about? So the sleepiness, So sometimes one of the earliest symptoms, GI can also sometimes be one of the earliest symptoms I learned today. The naps for hypersomnia are oftentimes not too restorative, whereas in narcolepsy, they can be very restorative. A 15-minute nap for a narcoleptic patient can just be like the fountain of youth. They're back at it. Family members, and I have definitely encountered this over the last few years since working with Dr. Day. Family members may endorse the sleepiness much more so than the patients. I mean, it's impressive, and you just confirmed it. Impacts quality of life, definitely. The cause, the pathogenesis of this does remain unclear. So how to evaluate sleepiness? So I'm just going to try to walk you through a sleep center evaluation. So we have subjective tests such as the Epworth Sleepiness Scale, which I'd encourage you all to kind of have a pen and paper in hand, and we're going to go through this real quick just to see. There's a question. These scales, as well as the objective tests to evaluate sleepiness, have not been well studied in myotonic dystrophy, and we probably don't have the right scale or the right test yet to objectively and subjectively report these sleepiness. Objective tests. So obviously the overnight sleep study, it's a night away from home, which can almost be viewed as a vacation to some, especially if there's children at home. And then a daytime sleep study. So let's go over the Epworth Sleepiness Scale. So a lot of words. I really try to limit words. But so this is a scale that you basically, how likely are you to fall asleep in these 8 different situations? And really what you need to just pay attention to are these right here. So 0 is never fall asleep, 1 is a slight chance, 2 is a moderate chance, and 3 is a high chance of dozing, okay? And I don't want you, so as soon as you see the situation, just think of the number. Don't debate. Just put down the number and then add up your score. So sitting and reading, what's the chance? In general, and if you haven't read it in a while or whatnot, just think about it. What's the chance? Watching TV, what's the chance? Not morning, noon, or night, just in general, what's the chance while you're watching TV of falling asleep? Sitting inactive in a public place, theater, or meeting, maybe today. As a passenger in a car for an hour without a break. I hear a chuckle. There's a 3 in the audience. Sitting and talking to someone. Sitting quietly after a lunch without alcohol. Interesting that they put that in there, but it's always in a car. And actually, this scale was developed in Australia. It wasn't like a siesta or something like this. Or it's interesting. In a car while stopped for a few minutes in traffic. And this one, it's intentional, I think. They don't say whether you're driving or not. And that always comes up. But just so come up with your scale. So add up the number of points that you had. And in the validations of this scale, a number greater than 10 is kind of deemed excessively sleepy. In some studies, the numbers of those 130 published articles, maybe 30% of 40 patients in one study had an Epworth score greater than 10. Another one, 50% of 43 patients had an Epworth scale greater than 10. So that's one part of it, right? The Epworth Sleepiness Scale. But we clearly haven't developed the right scale. And there's some other options too that I didn't cover. So let's talk about, once you see a sleep specialist, probably the decision if myotonic dystrophy, for the patient with myotonic dystrophy, is to look and see if sleep disorder breathing is at hand. It's interesting that I'm following a cardiology talk. So sleep apnea can actually increase your risk of heart attack and stroke, lead to high blood pressure. And so you can see if there's an inherent risk of cardiovascular issues in myotonic dystrophy, then trying to screen for this is quite important, perhaps. So an overnight sleep study. So you see the specialist, and then you schedule an appointment. You come in overnight. You sleep there. You get all wired for sound. And you thought you had trouble falling asleep without all this. We put all this on, and then we treated you. You go home, and you're like, oh, I can sleep finally. So let's look. So the first video that I was just on that last screen was basically just showing applying all the EEG electrodes to monitor the brain waves. These two, you know, so we're going to put eye electrodes on, which are demonstrated right here, and then we're putting chin electrodes on to monitor the muscle tone. It's fascinating, but when we dream, we're actually paralyzed, so we don't act out the dreams. So in one of those parasomnias that I mentioned to you, REM behavior disorder, where we're acting out where the person will act out their dreams, they've lost this paralysis or this inhibition of muscle tone. So what you can see is signature brain waves here, just as an example, what a sleep study looks like. We divide it up into 30-second increments, and you see the brain waves here. You see no muscle tone monitored right here, and you see rapid eye movements. And so you wake someone up right here, and they're more likely to report dreaming. That's not to say that if you wake someone up when they're not dreaming, they won't also report a dream. But clearly, Dr. Dement back in the 50s it's so funny to hear him describe these things. He would literally, he'd be watching the monitor, and then he'd see the rapid eye movements. What were you dreaming? He'd wake up, and a couple swings, he almost got hit, but nevertheless, we dream more when we do this. Other things that we're going to be doing when you come in here, we're going to put a snore microphone on. We're going to monitor your breathing with these respiratory belts. We're going to monitor your breathing right here at the nose and mouth. And then also we're going to, probably most importantly, monitor the oxygen with a finger probe. So just to show you a 5-minute clip of what sleep disorder breathing looks like, what we're looking at on the studies. And it's very complicated. It's an eloquent physiologic study with lots of parameters, but this is what it looks like, the finished product. And so sleep disorder breathing and myotonic dystrophy can be actual collapse of the airway. It can be a condition called central sleep apnea, which I just explained to patients that it's when the brain forgets to tell the diaphragm to move up and down. And then it can also just be a weakness, just not great excursion of the chest wall when you're sleeping. So hypoventilation is the fancy term there. So why is it? Well, it could be central, brain related, it could be weakness in the airway, and it could be the respiratory muscle weakness. The treatment is non-invasive positive pressure ventilation. It's a cute little mask that you wear and keeps the airway open or helps the chest wall move up and down as you're sleeping. Here are the different types, CPAP, bilevel, and then there's even more complicated devices to treat the sleep disorders, breathing. There's many mask options. If anyone in here has ever tried a machine in, say, 10 years ago, there's been significant advances and better masks, so I would encourage you to give it another shot. I see some nods, yes, in the audience. So definitely revisit, almost like a fine glass of wine, revisit positive pressure ventilation if it's been a while. Just to touch on this real quick, restless legs and leg kicking while you're asleep. So restless legs is described as an unpleasant sensation in the legs associated with an urge to move your legs, and that urge can be so significant. Worse at rest on a plane, in a meeting, today. Worse in the evening, but relieved with movement. So bad that you get in bed, I'm going to go to sleep, and then you feel this, and the patient describes, well, I had to get up, and I walk it off, and yeah, when I get up and walk, it feels great. But then I get back in bed, and it's a vicious cycle. So there's some good medications to treat this. Sometimes it can be associated with iron deficiency, so checking your iron levels. Ferritin level can sometimes find the cause. Periodic limb movements in sleep, just leg kicking. It's also reported to be more prevalent in myotonic dystrophy. So daytime sleep studies. We're going to first talk about the best day. It's an MSLT. Imagine a hotel, you're away from the house, no children, and I tell you, we're going to have you take 5 naps today. How could you resist? So, the worst day, imagine. Home away from home, and now I'm going to challenge you to stay awake for 40 minutes across the day. 4 episodes of this. So, one is to objectively evaluate the sleepiness. The other is to test responsive therapy. So the FAA oftentimes will require this of pilots that get diagnosed with sleep apnea or something, and to make sure that they can actually stay awake when they're flying. So the MSLT and myotonic dystrophy, just a few more minutes here. And so the dream sleep dysregulation, that's really a fancy word for myotonic dystrophy patients have been reported to dream more when they take a nap during the daytime. That's it. That's also seen in narcolepsy. They also fall asleep more quickly. On average, a lot of them will actually fall asleep in less than 8 minutes across a series of naps throughout the day. So what's the significance of this? Well, so I've danced around this issue, but if narcolepsy, a condition of central hypersomnia that back in 99, 2000, we actually discovered was due to a deficiency in hypercretin in the brain in the posterior hypothalamus. If the MSLT phenotype of narcolepsy is similar to myotonic dystrophy, might there be a connection to hypocretin? Well, there's one publication where one patient, we did a lumbar puncture, and they were found to have low hypocretin. But that was followed up in another study, and no one had low hypocretin levels. So while this is tantalizing and everything, it doesn't seem like hypocretin deficiency is the cause for the pathophysiology of sleepiness and myotonic dystrophy. So, the treatment of sleepiness in myotonic dystrophy. Screen for other sleep disorders, proper sleep hygiene. I didn't have time to talk about that today, but I just want to emphasize one thing about sleep hygiene. The most important thing for proper sleep hygiene, I don't know if I like the term, but that's what how we refer to it, is essentially dimming the lights in the evening and getting natural light in the morning. That is what the most strongest potent cue for your circadian rhythm. And so it's just key in maintaining a fixed wake up time in the morning and getting out and getting some natural light. If sleep disorder, screen for sleep disorder breathing. If it's present, treat it. If the sleepiness persists, then consider an alerting medication such as modafinil. Or modafinil is the one that's commonly reported. So rather than show you the 5 or so studies for modafinil, both for and against, the results aren't that great. This was a study, I think, that was reported in 2012. They sent out a survey to about 2,000 surveys to patients, myotonic dystrophy patients. Some were on modafinil, some weren't. One of the problems with this is obviously the patients that were on modafinil, about 130 patients or so responded, and about 90% of them were on modafinil. So they wanted to, let their voice be heard that modafinil is fantastic. So that's definitely biased here. But you can see through some of these descriptions here that it's the response to modafinil or stimulant is pretty darn significant and can definitely improve the quality of life from this. But when you read the studies, it's not nearly as impressive, and some studies show that compared to placebo, there was no difference. So what it boils down to is very careful patient selection, I think, and probably coming up with a better objective tests. So the conclusion, I think this is a common theme today. We need more data to better understand sleep-related issues in myotonic dystrophy to help and guide treatments. And so I just want to take 1 second. I don't have a flyer for this, but we have developed here at Stanford, as well as with collaboration with Harvard, Wisconsin, and UPenn, a online questionnaire. It's developed by this Academic Alliance for Sleep Research. It's online. You can create, you log in anywhere and create this. Maybe it takes 30, 40 minutes. I encourage everyone in here, if you're interested, you won't, to complete this survey, you won't get, unfortunately, at this point in the game, you won't get any feedback as to, well, we think maybe you have this condition or this condition. But it will definitely help us facilitate research and hopefully, translate into improved patient care. So if you want to do this, here's the information. Just send Eileen Leary an email, and maybe in the subject line, if you just type in DM myotonic dystrophy, so she sees that, and then she will get you set up with log-on credentials and encourage you to respond, click on it, and fill out the survey. That's it.